In the world of pathology, things aren't always what they seem. There are imposters out there, entities that look really dangerous, but are actually, believe it or not, completely harmless. Today, we're diving into one of the true masters of disguise, the adenomatoid tumor. It's a benign growth that has seriously puzzled doctors because it's so incredibly good at mimicking cancer. So here's our game plan. First, we'll cover what these tumors actually are. Then, we'll look at how they show up in a patient. After that, the fun part. We'll zoom way into the microscopic level, see how pathologists nail the diagnosis, and finally, we'll understand why this harmless little tumor is such a famous, or maybe infamous, mimicker. All right, let's start with the absolute basics. What exactly are we dealing with here? Okay, so at its heart, an adenomatoid tumor is rare and, this is the most important part, totally benign. The key phrase here is mesothelial origin. What does that mean? Well, it just means it comes from the mesothelium, which is basically a thin, protective layer of cells that lines our internal organs and body cavities, kind of like a biological bubble wrap. So, to break it down, we know it's not cancer. We know it comes from these special lining cells. And we know its favorite places to hang out are the genital tracts. For men, it's actually the most common tumor you'll find in the epididymis. And for women, it's often found chilling in the uterus and fallopian tubes. So let's shift gears to the clinical side of things. How does this tumor actually present itself to doctors? You might be surprised to hear that most of the time, it doesn't. Now get this. Most patients have no idea they even have one. These tumors are almost always asymptomatic. They're what we call an incidental finding, meaning they're discovered completely by accident during an exam or procedure for something else entirely. There's also some thinking that it might be linked to immunosuppression. And while it loves the genital tract, it can sometimes pop up in some really weird places, like the adrenal gland, the liver, or even the heart. So what does a pathologist see when they first lay eyes on it? Well, it's usually this small, well-defined little nodule, typically not much bigger than a couple of centimeters. It's got this grayish-white color and a firm, maybe even a little spongy feel to it. It's nicely contained, what we call well-circumscribed, but it doesn't have a true capsule sealing it off. But here's the thing. Those naked eye features are just the first clues. They aren't unique enough to make the final call. The real story, the one that separates this benign tumor from its dangerous lookalikes, is written in the language of cells. And to read it, we have to go under the microscope. This is where the real detective work begins. The patterns, the cells, the tiny little structures. This is where an adenomatoid tumor finally has to show its cards and reveal its true, benign identity. And here it is. This is a classic view of an adenomatoid tumor, stained with H&E. That's the standard pink and purple stain that pathologists use to see cell structures. At first glance, yeah, it kind of looks like a crazy maze of channels and spaces. But hidden within this beautiful chaos are three classic features that tell us exactly what we're looking at. We're going to break this down into three key things to look for: the overall pattern of the thing, the type of cells lining all those little spaces, and one very special, almost signature feature that's a dead giveaway. First up, let's look at the overall architecture. See how the tumor forms these gland-like channels and spaces? That's where the adenoid part of its name comes from. And this, right here, is a key reason it's such a great mimicker, because this pattern can look a lot like a dangerous adenocarcinoma, which is a type of cancer that forms in glands. Okay, now let's zoom in on the cells themselves. The cells lining these channels are flattened or kind of cube-shaped, and most importantly, they look bland. Now in pathology, hearing the word bland is fantastic news. It means the cells are uniform, they're calm, with nice round nuclei, and they aren't dividing like crazy. This is a massive clue that we're looking at something benign. And that brings us to the final clinching feature. Look closely here. See those delicate thread-like strands stretching across the open spaces? They look like tiny cellular tightropes. This is a classic, almost definitive sign of an adenomatoid tumor. When a pathologist sees these little strands, it's a huge sigh of relief, a sign they're on the right track. So, the microscopic features are super suggestive, but in modern pathology, we have an even more powerful tool to lock in the diagnosis: immunohistochemistry, or IHC. Think of IHC as a molecular fingerprint. We use these special stains that are basically homing beacons for specific proteins. For an adenomatoid tumor, the cells light up for mesothelial markers like calretinin and WT1, which confirms where they came from. But What they don't stain for is just as important. They're negative for markers like BEREP4, which helps us say, nope, not an adenocarcinoma. And they're negative for CD34, which tells us, nope, not a vascular tumor. It's a brilliant process of elimination at the molecular level. And we can even go one level deeper, to the genetics. These tumors often have mutations in a gene called TRAF7. But what's really critical is that they show retention of the BAP1 protein. Why does that matter? Well, because the loss of BAP1 is a hallmark of malignant mesothelioma, one of its most dangerous mimics. So seeing that BAP1 is still there provides another huge layer of reassurance. And that brings us right back around to where we started. We've seen all the clues that point to a benign diagnosis. So now, let's look at the lineup of imposters this tumor has to be carefully distinguished from. On the left, you've got the really scary stuff: malignant mesothelioma, metastatic adenocarcinoma, and yolk sac tumors. This is where those bland cells, those thread-like strands, and that very specific IHC fingerprint we talked about become absolutely crucial. They allow a pathologist to confidently say, this is not one of those. But it's not just about ruling out cancer. It can also mimic other benign conditions, which is why a super careful microscopic exam is always essential. So we end on this thought. The story of the adenomatoid tumor is just a perfect example of the challenge that's right at the heart of pathology. It's not just about identifying a disease. It's about definitively, confidently excluding all its dangerous lookalikes. It's a process of elimination where getting it right, well, that can make all the difference.